Good afternoon, everyone, and welcome to Billing for STD and Other Sexual Health Services, an example from the field. My name is Leandra Lacey, and I am the Associate Director of Capacity Building and Member Engagement for the National Coalition of STD Directors. NCSD is a national public health membership organization based in Washington, D.C. that represents health department STD directors, their support staff, and community-based partners across 50 states, 7 large cities, and 5 U.S. territories. Billing for STD and other sexual health services can be a critical component of sustainability for health departments and STD clinics. NCSD is here to offer tools and resources and to provide a platform for you to hear from peers and colleagues in the field regarding billing. So thank you all for joining today. All participants have been muted. If you have questions or need technical help during this webinar, please use the chat box on the right side of your screen. You can also privately message me or my colleague Desiree Smith, who is also listed as a host within Adobe Connect. All questions for presenters will be addressed at the end of the webinar, but we will keep a queue, so please send them our way as they come up in the chat box. This webinar is being recorded. The recording and presentation slides will be emailed to those that registered. These materials will also be placed on the NCSD website after the webinar. You can also find the slides in the Files box on the right side of your screen at the bottom if you'd like to download them today. Today's webinar will highlight updates to the STD-related Reproductive Health Training and Technical Assistance Center, or STD TAC, billing toolkit. It will also highlight the process of setting up billing infrastructure for an STD clinic and successes, challenges, and lessons learned in billing for services at an STD clinic. To kick us off, we'll hear from Wendy Nakatsukasa Ono, the President and CEO of Cardia. She'll be telling us more about the STD TAC billing toolkit and updates to the toolkit. I'll hand it over to you, Wendy.
Thank you, Leandra, and good afternoon, everyone. Hope that you're doing well as we continue to navigate a range of challenges across our country, including the most recent winter storms that have impacted Texas and other parts of the country. So hope you're doing well. I am going to start off by giving you a really brief set of background information on the STD TAC billing toolkit and how it came to be. The STD TAC billing toolkit was funded by a cooperative agreement between CDC and the Office of Population Affairs, and it was really designed to improve the sustainability of state STD programs and clinics and of public health labs that were providing STI testing. It was developed by JSI Research and Training Institute with support from the other regional STD-related reproductive health training and technical assistance centers, or TACs. The toolkit was originally designed to build stakeholder capacity to really go from A to Z with billing. So really to start with assessing the feasibility of billing and reimbursement for STI services, and also to scale up billing and reimbursement systems. To update the STD TAC billing toolkit once NCSD took over the administration of this resource, we really went through a very thoughtful process of reviewing each section of the toolkit, determining if links were active or not, finding new links where those were available for any resources where links were broken, and identifying some new billing resources. And so NCSD then updated the toolkit based on the considerations provided as part of that process. The STD TAC billing toolkit on the NCSD website includes a roadmap and 5 modules, and I'll just do a very brief overview of those 5 modules. So the roadmap is really just more information, as the name suggests, about how to navigate the toolkit and define some of the commonly used terms in billing. Module 1 really starts at the very beginning, so it starts with that assessment process. So it looks at outlining reasons to consider initiating third-party billing and provides some of those necessary resources to help get that process started. In Module 2, developing billing systems, this module really covers all aspects related to developing a billing system specific to state and local STD programs and clinics. Module 3 focuses on managing the revenue cycle, so providing a range of e-learning resources to build clinic and lab capacity and revenue cycle management. Module 4 really talks about initiating the contracting process. For many of you who have been engaged in billing for a little bit of time, you know that that process for contracting with third-party payers can be a little bit of a sticky part of the process. And so this module really provides lessons learned, tips, and FAQs for how to manage that contracting process. And then the last module is focuses on enhancing coding capacity. And so it features some introductory resources on coding for both reproductive and sexual health services. So at this time, I think I'm going to turn it over to Phil.
Great, thank you, Wendy. Can I get a sound check to make sure I sound okay?
You sound good.
Great, thank you all. So thank you, NCSD, for hosting. Thank you, Wendy, for that overview. So my name is Phil Chin. I'm an infectious disease physician. I have a couple roles here in the state of Rhode Island, on staff at Brown. Also serve as director of a STD clinic that I started at our local hospital system called the Miriam Hospital. It's a partnership with our Rhode Island Department of Health, where I'm also on staff at. It's state supported, but it's actually based at our HIV clinic, our largest HIV clinic in the state. And that's something I started back in 2011, 2012. I'm also recently served as Director of Research and Population Health at Open Door Health, and that was a clinic that I started with a group of people that I'll chat about shortly, related to an STD program for the LGBTQ plus population. So I'll chat a little bit more about that as we talk through this. I think my role here is to give sort of a broad overview about billing and lessons learned. I think, as we know in the U.S., that limited public health funding exists for STI clinics, and so I'm fascinated that there's so many people on this call, and I love it. And I know that this has been a hot topic for the last several years, like how to leverage billing, both insurance and other grant mechanisms, to fund STI programs. And I think it's a critical question. And one that can be complicated, which is one of the reasons why we're here today. So just a little bit more background, just to give you some context for what I'm going to talk about in my experiences. And again, I just want to emphasize that every community, every setting, every program is a little bit different. And I recognize that everyone has to sort of figure their own way to navigate some of this. But I do think there are some important lessons learned in general. And so to put this in context, Rhode Island, small state in the country, we essentially have one major HIV clinic through our Brown University, hospital system, and the HIV clinic sees about 80% of the state's positive population. And back in 2012, I actually borrowed a room at our HIV clinic and started an STD clinic out of that one room that has since exponentially grown to see about 4,000 people a year, and it's much larger than a room now. And they actually built out a separate space for it at our HIV clinic. And so initially, all services, again in partnership with the Rhode Island Department of Health, all services were anonymous and free, and we were treating people, et cetera. I mean, it was really based on a public STI clinic model. And over time, certainly with some encouragement, if you will, by the hospital system, we implemented a sustainable financial model for this clinic. And now it bills insurance for people, for patients coming in, and there's financial assistance that people can apply for if they don't have insurance. One of the more exciting initiatives that I've led in this past year, it actually opened the day after our first COVID case here in Rhode Island, so not great timing, and let's just say there's been a lot of challenges. But this was a clinic that I started from scratch with an institution called Rhode Island Public Health Institute, led by Dr. Amy Nunn, who's executive director. really a group of us, also with Cassie Sutton-Coates, who is the operations manager of the clinic. And I will say that she really took lead on figuring out a lot of what I'm going to talk about related to billing and EMR. Has really been the heart and soul of the clinic in pushing that forward. So I want to acknowledge her efforts, et cetera. So this has been, the hospital-based clinic. I think with any larger clinic system, there's a lot of infrastructure that comes into play. Open Door Health was a unique experience in that it was built from the ground up. I mean, literally, there were 4 of us initially that picked out a clinic space, built it out from scratch, chose the EMR, built out the EMR from scratch, and implemented all these different financial and billing services. And some of those are experiences about what I'm going to chat about today. The clinic itself does do primary care. That was one of the reasons we built it out. And the other was to have a walk-in based STI screening program as well. Just briefly, lots of considerations for costs. As we talk about STI clinics, certainly infrastructure, laboratory costs, staff, of course, medications, other things that aren't routinely considered, vaccines, sharps, having an AED, Narcan, Epi, et cetera. So, I've spent a lot of time looking at different business models and pricing out some of these things. And the way that I think about how to fund these clinics, how to fund any program in general, right? There's 5 basic categories. I think public health funding through the federal, through the feds, through the state, patient billing, which we'll talk a little bit more, billing insurance, private funding. So that's, for example, support through a hospital, through a larger clinic system, philanthropy, et cetera. Then there's research funding and other grant funding, NIH funding, foundations, et cetera. And then 340B. And we'll talk a little bit more about the 340B mechanism in a second. And for me, as I've thought about how to build out STI programs, I think, there is funding from public health departments, carved out of CDC grants, et cetera. Some states do get dedicated funding for STI programs. In the state of Rhode Island, we actually have no state funding for our STI program. So everything we get is right from the federal government. And I'm guessing that's probably similar for a number of other folks on here. But nonetheless, there is money, not a lot, but through public health to fund some of these STI programs. And the other 2 things I really want to drill down on, especially as we think about achieving sustainable models of funding, include how to bill insurance and what that really looks like, as well as this thing called 340B. And I'll talk a little bit more about that as well. I think one way that I think about grants, there's lots of grant opportunities out there. I've had a number of NIH and other grants myself, and the way that I think about approaching grant funding is, grant funding tends to be a pot of money, tends to be limited in time, and so I use it to expand programs. So it's not necessarily to sustain a program, right, because it's limited, finite duration, but I love grants because it allows you to sort of build things out, implement, future vision, next stages, things like that. So I'm a big proponent of grants. But I do not think that they're really great for sustainability purposes, right? Because they run out, time limited, et cetera. And finally, hospital philanthropy, also fantastic, of course, but likewise, that's not a steady source of sustainable funding. So we definitely leverage all of these, but just sort of highlighting what could generally is more sustainable. So let's talk about clinical billing for a second. So my experience is related to clinical billing is that there's parts of it that seem complicated that are not, and there's parts that people are probably unaware of that are actually incredibly complicated. So we chose an EMR, and I've worked across several different clinical systems, all with different EMRs, et cetera. And in my opinion, largely, all EMRs are pretty much created the same. And so, they're all essentially meant to bill. Like if you get to the heart of what an EMR does, of course it documents clinical documentation, but the other 50% of it is these systems are built to bill for clinical billing. So if you're going to bill, you need an EMR. So if you don't have an EMR, that's something to consider. And if you look at the most common popular EMRs, in my opinion, and we check out a bunch, I've used a bunch of them myself, from Cerner to Epic to Athena Health to eClinicalWorks. I don't know, there's some other ones out there. And they're all very similar. I mean, there's all a million buttons, right? And there's a back end, and a lot of them take care of the billing. We'll talk about that in a second. But, as long as you go with one of the more popular ones, they tend to be very similar. I think the first thing to note is they generally take a few months to set up. So it's not like something to say, They don't come out of the box. It's not like you could say tomorrow, like, I want to implement an EMR. You have to plan for it, and it takes a few months. And I think one thing that you learn about these EMR systems is that there's many different options, bells and whistles that you can choose, of course, a lot of them with an added cost. But these include things like ways to communicate, patient portals. You have to set up provider accounts. You have to build out scheduling, right? You have to sort of build out what your clinic looks like, the times that you can schedule the different providers. There's clinical templates and intake forms, and you got to load up fax numbers and set up inboxes. And so there's a fair amount of setup and communications with the EMR in the beginning, and they have people that do this. So they walk you through it. So it's not like you have to figure out everything on your own, but they'll ask specific questions. There's a representative from the EMRs, and they'll walk you through it, setting up everything. So it requires time for sure. But there's help there is kind of the point that I want to get at. I think one thing that I was unaware of and have learned through some of these processes is the incredibly complex nature of billing insurers. And the EMR itself, I feel like, is pretty straightforward once you get there. But it's really this concept of billing insurers and credentialing with insurers. So that's a separate process I want to highlight. So assuming you have providers at your clinic, which I assume you do, is that they have to all be credentialed with insurers, which is an entirely separate, lengthy process. They have to be set up with the insurers, and then each insurer needs to be set up in the EMR to link it to the providers. And that is a complex process. And I think out of everything that kind of keeps me up at night, if you will, and kind of gives me the cold sweats when I think about it, that is a tedious process, because at least in Rhode Island, small state, we have a few major insurers. We have United Healthcare, of course, and we have Blue Cross Blue Shield, and we have a couple other ones. But it's really a limited number. I mean, I couldn't imagine doing this for a larger state that may have a much more complex medical system with multiple insurers. So this, to me, still continues to this day, a year into this process, still takes up a lot of time. It always seems like there's something else that the insurers need, et cetera, et cetera. So this is, to me, the most complicated component of this, and we can chat a little bit more about this as well. I think the one thing that was kind of simple, actually, which caught me by surprise, was that each EMR, and there's private vendors for this, but each EMR has usually a billing component to it that they do automatically, meaning there's an EMR component, but then they also have a billing service that they can usually add on. And so, for example, for what I've done, they tend to take 7% of the cost off the billing, and it's automatic, and it feeds in, of course, to an account, et cetera. So that part's relatively simple, which I was actually shocked at. I mean, it was incredibly simple. It's really that credentialing and the interface with insurers that continue to this day to be incredibly time-consuming, and we essentially have a full-time person on it. I think the other thing to keep in mind and to look at, these are some examples from a couple of years ago when we published, but as you think about billing and sustainability and building out business models, the reimbursement for Medicaid is not that high, and you can see that on the right column here. So these are the billing codes for new patients. These are the billing codes for follow-up patients. Again, if you look at like a level 3, and that's, I guess, typically what people usually bill, if you will, the reimbursement for a new, let's say, STI patient is $29, right? And so follow-up would be $20. And so, most clinics have found that they cannot sustain services alone based on billing a large percentage of Medicaid. And I think that that's a critical component, certainly for most of us in public health and who provide safety net service, right? A lot of our patients are uninsured. A lot of them may be Medicaid, et cetera. Just interestingly, this is one example from the past of the list cost of what certain healthcare systems, at least in our state, bill for some of these services. And you can see many fold higher if you were to pay out of pocket for a level 3 new visit. It's $207 compared to Medicaid $29. So I think to hop on a side note, I think transparency in cost in the healthcare system in general is important. I know there's some movement to do that, but when you start to look at that, I mean, it really turns out to be quite impressive about what you find. And we've modeled out our clinic before. This slide just shows essentially that blue line shows that that we would have to see a large number of patients. Essentially, we'd have to, for a standard clinic, this is our clinic, offering a basic set of STI services to break even, we would need to cover 73% of patients at the Medicaid rate, 38% at a private rate, or 11% at an institutional list rate. And this doesn't account, actually, this was based on projections from our hospital-based system. So this is talking about room and infrastructure already being covered by cost. And so if you were a program to have to cover all the rent and utilities, like you can see here, that Medicaid billing would not be sustainable, et cetera. The other thing about Rhode Island, too, that's been nice is that it is a Medicaid expansion state. We have one of the highest rates of insured people, meaning only about less than 5% are considered uninsured. But we still notice in our clinic that a significant number of people are uninsured. So 40% in our state are uninsured. And I think for all of us that work in this field, we know that there are numerous barriers to obtaining insurance. And what the insurers have done over the last decade is to really push out-of-pocket costs onto, if you will, patients, to consumers, et cetera, in terms of deductibles and copays. And these can be really significant barriers to obtaining STI care. And even among those who do have insurance, there's many people. We found that over 50% of people do not want to use their insurance for various reasons. One of the reasons, as I just mentioned, is copays, deductibles. The other thing, though, of course, is for a lot of patients, this is still highly stigmatized, and a lot of patients want to remain anonymous or confidential. And for all insurers, most insurers, a lot of insurers, they send home explanation of benefits where a potential partner, a potential parent could see them, and obviously that would be a concern if for some people in those situations. So one thing that we've done for our community clinic, and one thing that a lot of clinics do, is to leverage what's known as 340B. And so I'm guessing that many of you have heard of this. I just wanted to have one slide to explain what this is, because this is complicated, to be honest. And when you drill down to it, it's even more complicated than you think it is. So what is 340B? So 340B is a federal law that requires drug manufacturers, pharmaceutical companies, to offer discounts on medications sold to specific safety net providers, outpatients, like STI clinics. It's administered by HRSA, and the term 340B refers to the actual Law Regulation Act, which describes the program. And so if you can understand that, it's basically a pharmacy program where manufacturers who participate in Medicaid, which is essentially all of them, sell outpatient drugs to the entities at a reduced price. So, for example, I'm a clinic. They sell the medication at a discounted price to me, and then the clinic, us, essentially bills the insurance companies at full price or whatever the insurers will cover. And so the clinic gets to keep the difference. And so what is a covered entity? Covered entity refers to really safety net outpatient clinics. So these include FQHCs, FQHC lookalikes, Ryan White programs, STD clinics, family planning clinics, and really other safety net systems. So as you look at what 340B, how it actually works, and the reason why I'm sort of drilling down a little bit on this is because, just to be honest, I mean, this is how we're covering the costs at our community-based clinics and how community clinics are able to sustain. So if you have an STI program, if you are looking at avenues of sustainable funding, I would strongly encourage you to get familiar and understand 340B, as it is what generally a lot of these clinics do to sustain their bottom line. So let me just walk through one example here. So without 340B drug pricing, right, a provider usually writes a prescription for medication. The patient goes to the pharmacy. The pharmacy, has bought the medication from a wholesaler. Let's say there's a price tag of $900. The pharmacy bills the patient insurance, and the insurance company reimburses the pharmacy for $1,000, and therefore the pharmacy earns $100. And so this would be for like a single 30-day. So what happens with 340B drug pricing is that similarly, a provider writes a prescription for the medication. The patient goes to the pharmacy. Now, the pharmacy bought the medication from not just a typical wholesaler, but a 340B wholesaler, at the 340B specific price of $400. And this is what exactly happens, right? So for the normal mechanism, they bought it at $900. The 340B price is $400, and they bill the insurance company. The insurance company still reimburses the pharmacy at the same level, so $1,000. And now instead of the pharmacy earning $100, the total income that's been made is $600. It's $600, so the pharmacy still gets $100, and now $500 goes to the clinic. And so $500 to the clinic for a 30-day medication, multiplied by perhaps hundreds, if not thousands of patients, that adds up. And there are some clinics that make hundreds of thousands, if not millions of dollars of this a year, and obviously it can be very lucrative. And it's meant to sustain clinics like STI clinics, and this is what it was meant for, and it works. And I encourage people to look at it. The drawbacks in general of 340B considerations is that because of obviously the money, it needs strict oversight. It needs policies, reporting structures, audits. There's program requirements. You have to register in a 340B database. You have to, recertify annually. And you have to identify a contract pharmacy to purchase the 340 medications. And I will say that we've contracted with CVS. I know that Walgreens also has a program. A lot of the major pharmacies have 340B programs. And the good news is that they have people that are knowledgeable that can walk you through it. So we had to learn and be walked through how to set this up, and they did it. And it was great, and it was time consuming, but it was easier than I thought, et cetera. So again, one of the key components is that you do need to be a covered entity, and STI clinics in general do qualify. So if you are an FQHC, if you're an FQHC lookalike, it does count. The other way, and what we've done through some of our clinics, is that there is there's a CDC STD prevention grant, and there's a section in it called the funding, Department of Health get funding through Section 317 or 318. And so the health department has to designate you as an official STD clinic with some support somehow, and it can be financial support or it can be in-kind support through property, equipment, services, et cetera, that qualify under the CDC grant. So again, if you're interested in receiving an STD clinic designation specifically, you should talk to your public health department about receiving an official designation through what's known as Section 318 of their CDC grant, et cetera. And if you are an STI program or frankly, any program, clinical program that provides STI services, you can qualify for this. The other thing that I want to mention is how, some of the ways that people leverage different approaches to maximize the 340B program for STI care. And one is that if you think about how a 340B program works, is that the more expensive the medications, the more the difference between the 340B wholesaler as well as what's billed to insurance. And so what that means, wearing my public health hat, I sometimes feel a little bit dirty talking about this, to be honest. But what it means is the more expensive the medication, the more lucrative it is to your clinic, essentially. And so if you think about what medications are most expensive, these include HIV medications, at least in the sexual health realm. These include HIV medications, it includes PrEP medications, and it includes Hep C medications. So if you are an STI program, and what we have been building out, and what has been built out at other clinics that I work with, is that if you, for example, prescribe PrEP through your STI clinic, you can, offset and sustain the STI program at a pretty good amount based on the 340B revenue. And so that's one thing for folks to consider. If HIV care is prescribed is provided at your STI clinic, or medications are refilled, you can also generate a fair amount of money to offset the cost of STI care, and similarly for Hep C. One thing I will mention, though, for PrEP at least, is that very recently, the medications that have been used for PrEP are Truvada, which is brand name from Gilead, Descovy, brand name from Gilead. Recently, Truvada also went generic to tenofovir disoproxil fumarate and emtricitabine. And the generic 340B price is essentially, for us, it's been a break-even point for 340B. So there's some considerations with PrEP and other medications and 340B that we're still in the process of learning. But I do want to encourage people to look at this program and to consider some of these other avenues for sustainability. So in conclusion, to fund STI programs, I think people have to be creative. I think it differs a bit depending on your community and where you are, but really multiple sources of revenue should be considered. And at least for the STI clinics that I've seen here in our state, is that they are not sustainable by clinical billing alone. And we've had to leverage other things like 340B. Really, it's the main way to offset the cost. Obviously, there's other mechanisms to achieve financial sustainability, and those should all be considered. But really what I've seen from a lot of places is that the way that this is done is a combination of clinical billing and 340B. So I think I'll end there. I'll hand it back to Leandra to field any questions, and happy to answer any. So thank you everyone for your attention.
Awesome. Thank you so much to Phil and to Wendy as well for your great presentations. We've got some really good questions in the chat box, and feel free to keep those coming. We'll continue to have a queue of those questions as our presenters are answering them. So, Phil, for the first question, Judith asked, on the slide where you were demonstrating the number of visits by insurer required to meet financial expenditures, it said 2,000 Medicaid visits were required. Was that 2,000 visits per month? She just wanted a more explanation for that.
Yeah, we actually calculate that per year. I think that varies, of course, per clinic site, and I think that's one reason why I presented it as percent. So what we found at our clinic, based on the fact that at the time that this was done, we were seeing about a couple thousand patients a year, was that we needed the majority, 73%, to be covered at the Medicaid rate in order to be sustainable. And this was assuming in a structure, in a context that the rent and the utilities and things were already covered. So, yep, good question.
Great, thank you. A question that I got sent directly to me was, this is from Katie. Katie says, what about nurse-run clinics to get credentialed for billing? We have one NP and the other staff are RNs that have standing orders from our medical director that's not on site. Can we get credentialed as a clinic, or does it have to be for individual providers?
Yep, so that's a good question. And Wendy, feel free to chime in on any of these. Some of these may be state specific. So you do, it's my understanding, at least for our state, that you do have to have an MD medical director sign off. But if you do have standing orders, like absolutely, a nurse practitioner, a physician's assistant can bill for services. And that can be a more cost-effective way to sustain programs because generally NPs and PAs are paid at a much lower rate than MDs. So absolutely, and we use that model as well.
Thanks, Phil. The only thing that I would add is that certainly standing orders have been used in a lot of programs. Also, there are some provisions in states that allow for nurse-only, RN-only visits, but there are some challenges with reimbursement in some cases for that. Again, it's pretty state specific, so I think the best course of action is just to get some particular advice and counsel from others in your state on what works best.
Great, thanks to both of you. Our next question is from Elizabeth. Hi, Elizabeth. Are there any national level efforts to address the issue you mentioned related to inadvertent disclosure of confidential services, especially for adolescents, through EOBs or explanation of benefits? This has been discussed for years, but it is still a tremendous barrier to care.
So I can take first shot at that. I will say that national efforts, no, I'm not aware of. There are a number of statewide efforts, and I will point people actually to California, who has what I think is really the model approach to this. And they have essentially, and I last looked into this about a year ago, so I apologize if things have changed. But they essentially have a one-page form where someone who's presenting, frankly, for any services, but STI services, can fill out a one-page form that can send explanation of benefits to an alternative address, et cetera. So people can fill that out and have it sent, and that by law, I believe, has to be honored by insurance companies. So I'll say here in Rhode Island, we're actually looking at a similar model. We were actually had good progress on that, and then the pandemic hit. So it's something we're actively exploring in our state. But I think the bottom line is a lot of efforts are state dependent in initiatives in terms of looking at how EOBs are reported to patients.
Okay, thanks, Phil. The next question comes from Laura. Laura asks, how does your clinic handle carving out Medicaid patients? Is that a tracking/purchasing nightmare?
Yeah, so my understanding of this is that you have to be very careful. So one thing about 340B, and I think what this question is alluding to, is you need to be very careful about Medicaid and Medicare patients, because sometimes what happens is the state itself gets rebate dollars from manufacturers based on medications that are prescribed. And so what happens is you get something known as duplicate discounts, where we as a clinic would get a discount through 340B, and the state may be getting a discount. And that's an audit red flag that is not allowed. And that's sort of one of the reasons why I was talking about is you need to be very careful about what you're billing for 340B. You need everything to be well documented and et cetera. And the program and the pharmacies will help set up for that. What I understand for a lot of clinics that do, and we do, is that we actually don't use the 340B program for Medicaid specifically because of the concern for duplicate discounts. And it's not always clear, and it's still not clear to me. I've actually been looking into this as of lately as this week. So there are some nuances of the program that folks have to be careful about. Again, some of the consultants and the contract pharmacies can help navigate this. But to your point, at the end of the day, we don't use 340B for Medicaid patients for this reason.
Awesome, thank you. Another question I got from Katie that was submitted to me directly. For 340B, what if our clinic dispenses medications on site, not prescriptions? Can we still bill for more than we are paid for the medication?
Oh, sorry, you broke up a little bit there. Can you repeat once more of the question, if you don't mind? Oh, I think it was a question about where the medication is sent to and pharmacy reimbursement. So I'll let people know that when you identify so this is one of the cons of the 340B program. When you do use the 340B program, you do have to send the prescription to a specific pharmacy. So, for example, we've contracted with CVS. We have to send the prescription specifically to a certain CVS that's close to us, where patients should fill it up. So I could not send for example, a PrEP prescription to Walgreens or even a CVS on the other side of town. It would not be covered through our 340B program. So that may be a limitation for some people. For some of the models that I've seen that have been successful leveraging 340B, if you have an in-house pharmacy, that's actually phenomenal, and then people can pick it up right there once you prescribe it. So that may have been what the question was getting at. I apologize if not. I was cut out for part of it.
Sorry, Phil, when you asked me to repeat it, I was repeating it, but I was on mute, so you did not hear me. Sorry about that. So, yeah, I think you covered the question fine. Thank you so much. You can hear me now. Okay, just making sure I'm off of mute. Let's see. For the next question, I think, let's see, Margaret asks, this is also a 340B question. We purchase therapeutic and birth control medications through 340B, which we dispense directly on site to patients. How do we make money, in quotes, with 340B meds in this scenario? If we can bill Medicaid for the medication, can we bill Medicaid for the medication on a patient's behalf if we charge the patient for the medication as an out-of-pocket expense directly? Phil, is that clear? You may have answered this a little bit earlier too.
Yeah, so I think it's clear. So The 340B, there's a couple things here. The 340B prices directly to clinics for medications are much, much, much cheaper than the overall wholesaler cost. So just by the fact that you can purchase medication for the clinic at the 340B price, I mean, you're already saving a ridiculous amount of money. And then you should be able to bill the medications to the insurance company for what you've dispensed to cover costs and raise money that way. So I believe that's what's being asked, and yes, you can do that. But the other important point is that I would, just to the previous comment I made, you want to be careful about billing Medicaid. Again, it's state dependent, so you need to make sure before you bill Medicaid for a 340B medication that the state Medicaid program is not getting any rebates or reimbursements from pharmaceutical companies on the back end. And sometimes that's not always clear.
Gotcha. Okay. Do I still sound clear, Phil, through my headphones? Or I'm trying to figure out if I need to take them out. Am I still okay?
Sound good?
Okay, perfect. So for the next question, Pierre asks, how do you handle billing for people who are insured but not in your network? Are you allowed to pick and choose who you bill?
Yeah, so great question, and this gets to the heart of one of the things that I was sort of pontificating about, which is the having to credential with insurers. So, unfortunately, if you don't credential with a specific insurer, then they will not pay you, which means that essentially the person can pay out of pocket, the clinic can eat the cost, et cetera. And that's why you'll hear, you'll hear clinics advertising things like, we accept XYZ insurers, and that's exactly why. So if you're not credentialed with a given insurer, then they won't cover you. So, some have in-network, some have out-networks. I mean, that's one thing, again, just to get it with the insurance industry, is that it's incredibly complicated, and every single insurance company is slightly different. Every single state slightly different, which creates a confusing and opaque type system with lots of administrative hurdles in order to get any money. And so that's just for us. That's really been one of the biggest barriers to implementing billing. It hasn't been the EMR. It hasn't been staffing in clinical care. I mean, it's really been the credentialing with insurers in order to get paid has been really one of the biggest things and time-consuming things, frankly, to getting billed.
Awesome, thank you. Then Susan asked, what percentage of 340B medications were actually reimbursed by payers, and what percentage were uninsured clients?
Yep, good question. And so this is one of the first things that we did. And as you start to look at and think about implementing billing services, or frankly 340B, I mean, one of the first things that you have to do is break down your patient population and ask, the questions are, well, what percentage of patients are uninsured? What percent have Medicaid potentially or Medicare? And what percent have private insurers? And based on that, I mean, that's how you can make decisions, both about clinical billing, about 340B, and that really gets at sort of the business plan and path to sustainability, et cetera. So it varies per clinic for sure, and per setting, and that's exactly what you want to account for. And it's really the percentage of people who have private insurers that 340B can be most effective in terms of providing some safety net funding. So it's really private insurers that 340B works best with. And so, for all of us in this field, I mean, we all, at least everyone that I know of, provides care, to some degree to uninsured people who are underinsured. It's a huge problem. And again, it goes back to my pitch and my push for multiple models of funding. And so for uninsured people, we just eat the cost, but it's offset by the 340B funding. And at least for us, that's where philanthropy, through work with our state health department, is that there is some of this grant funding that can kick in for safety net services to cover to offset some of the costs. And that's why just making a strong push is that for the need for these multiple funding sources, because you can't rely, especially, in the field of STI, safety net services, you can't rely on clinical billing alone. Because we have to take care of those who are uninsured and underinsured, and you just can't do it with clinical billing, and you can't do it with Medicaid predominant populations alone, or it's going to be very tough to do.
Awesome, thank you. And then Cherie asked if folks have recommendations for a billing company they could contract with. And Phil, I don't know if you've shared your successes and lessons learned and challenges with other folks in the STD field, but I don't know if you could answer this. I do want to say as well, before you jump in, Phil, that Jenny Mon, my colleague here at NCSD, our Associate Director of Clinic Programs, if you have any specific STD clinic TA or technical assistant that you would like, you're welcome to get in touch with her, or my email is on the slide here. You can get in touch with me, and I'll make sure you get in contact with her. And then 340B, I know we've talked a lot about 340B today. Stephanie Arnold-Pang, our Director of Government and Policy Relations, does quite a bit of 340B work and has also provided technical assistance to a lot of our NCSD members. So you're welcome to also reach out to her if you have any specific 340B questions. But yeah, Phil, do you have any recommendations for Sherry's question? Or Wendy as well, you're welcome to jump in too.
Yeah, so I'll say that a lot of different, some of this also setting dependent. So what I would suggest to get to this is to actually look at some of the clinics in your area, so the FQHCs in your state, in your county, and I would ask them who they use, and that would be the way that I go. If you have an EMR, again, a lot of the EMRs have components that have billing services which integrate with their EMR. So I would go with that route as well, because a lot of times it can be, or I would explore that route as well. And finally, I just want to say in regard to Stephanie Arnold-Pang is that she really is a wealth of information to 340B. She's who I go to with questions. I consider myself with average knowledge about the 340B program, but definitely Stephanie is a phenomenal resource that I utilize all the time. So thank you, NCSD and Stephanie.
I agree, Phil. Yeah.
Oh, thanks, Leandra. Yes, I echo everything that Phil said. One consideration in working with a billing company is that there is still a lot of capacity and infrastructure that needs to be built up within your system in order to ensure that you're getting what you need out of any billing company that you would contract with. So I would encourage you to be thoughtful about looking at the capacity and infrastructure that you have within your clinic or within your program, and making sure that you have a sense of some of the right questions to ask going into those conversations. Because again, you're going to be the most knowledgeable about how to code, how to document the work that you're doing that will actually, provide the foundation for billing. So it's really important to think about both. A billing company can certainly be helpful, and it's important to make sure that you're well informed going into that process.
Great, thank you. And my colleague Desiree has pasted Stephanie's information there and Jenny's information as well, if you'd like to contact them at NCSD. I don't see any other questions in the chat box, but I do have one to pose to our presenters. So we know that a lot of sexual health clinic staff continue to be redeployed to COVID-19 efforts in their jurisdictions. So how are clinics filling the gaps financially if they relied on clinic revenue from sexual health services that have been drastically reduced because of COVID?
Yeah, I can speak from experiences from our state. That's a tough question. What's happened is that people have been moved around. So, even myself, I've been pulled into a lot of COVID stuff. But a lot of our STI clinic staff have, we've had to be innovative and flexible. And a lot of the STI clinic staff have been pulled into various other activities. Certainly on the Department of Health side, I think as this question is alluding to, a lot of DIS went to, do contact tracing, quarantine isolation for COVID patients on the public health side. And on the clinical side, what I've seen is a lot of patients get pulled into other things like COVID testing or now COVID vaccinations. So a lot of the STI clinic staff have been pulled into many other things. And frankly, some people have been placed on leave, some of the non-clinical people, people like some of the counselors and outreach workers, et cetera. Some people have to have been let go. So, no great answers for that. I think a lot of it depends on your site and your setting, but these are some of the experiences, at least from our state.
Like Phil, I think our experience has been very much the same. I would say I would go back to the point that Phil made earlier, which is that billing and reimbursement can be a very good tool for STI programs and clinics, and at the same time, we are safety net providers. And so, at the end of the day, it's one piece of the puzzle, but it's not the whole thing. And I think as we're responding to other public health issues like the COVID-19 pandemic, we need to be thoughtful about the ways in which, and I recognize that I'm preaching to the choir on this one, but I think we need to be thoughtful about the decisions that we're making about how much burden we put on programs and clinics that have a public health mission to be doing that in this moment.
Yeah, thank you both for sharing your experiences. I'm sure some of those experiences are pretty common across the country as things are, I was going to say changing weekly or monthly, but honestly it's changing daily in a lot of places. So thank you for sharing that insight. David has a question. David asks, are there any scenarios where a community health worker or a medical assistant can bill for HIV/STI testing under a provider?
So we have, not that I'm aware of, I'd be curious, Wendy, if you have any thoughts on this. You can have nurses work under standing orders, and I believe that they can bill at a very low level, level 1. But medical assistants and other staff generally no. Wendy, do you have any thoughts about that?
Thanks, Phil. I'm also not aware of any programs that are currently doing this successfully in spite of building up, infrastructure for certifying and training community health workers. I know that there were a few states, Colorado, Minnesota, others that are not coming to mind in this moment, that were looking at options for doing that. But I haven't personally heard of any that successfully have that going in this moment.
Okay, thank you. Margaret asks, our local health department STI clinic will be moving to EMR and ideally billing in 2021. They were saying they'll check out the toolkit. Thank you so much. It's mentioned in the web links box, and I'll also send out that link when I send out the slides and the recording. But Margaret says, it feels daunting to figure out billing. What are good first steps and resources to look into as we prepare to launch those endeavors? Thank you for that question, Margaret. It's really good.
Yep, sorry, a little bit of feedback there. Question related to building out what components of the EMR?
So it was more so just about what are good first steps for people that are just starting this process, because it can feel daunting. So what are good first steps and resources as people are looking into, preparing to launch into the billing process? Did you hear that?
Yes, thank you. Sorry. My suggestion, and then I'd be curious what Wendy thinks as well, is to hire a consultant or make sure to have someone on your staff who's familiar with some of the billing practices. So the EMR is the first step. You then have to figure out a billing service. And again, a lot of times the EMRs have billing services, and you may want to consider that for ease. And then the other thing is to have someone familiar with coding, et cetera. And someone really needs to just be that person who interfaces with the EMR to learn, all the nuances and nuts and bolts of, what the billing looks like. And again, all these EMRs have components, modules that really drill down on billing and et cetera, et cetera. So you just that one person to really become familiar. And what we've done is we hired, and I would suggest this, is that there's people who are experts in this and make their living off this. I would suggest spending a small amount of money and looking for one of these people that really does this for a living and having them provide some guidance out there. I don't know. Any thoughts, Wendy?
Thanks, Bill. No, I think everything you've said is great. I would also refer you back to, if you really are just at that very early stage of considering billing, I really would point you to Module 1 of the Billing Toolkit, because I think it has some helpful resources that raise some of these kinds of questions and issues that Phil just elevated. I underscore getting somebody who can really dive deeply into your system and the way in which you provide services. That's critical to understanding how and to what extent billing may actually be important for your program and may actually help you achieve the goals that you have outlined. And I guess the last thing that I would underscore is that it is important to have sort of an expert within your program or clinic, but it's going to take a team approach to really make sure that billing is successful. It's not just something that gets handled by the billing or finance department. It really is something that everybody from front desk to clinical providers, everybody needs to be on board because everybody holds a little piece of the puzzle in all of this in order for billing to be truly successful.
Great, thank you. Such a good point, Wendy. So Katie had a question. Do the nurse visit reimbursement billing rules vary by state? And there's been some good discussion in the chat box replying to Katie's question, saying that the guess is that those are federal and the visits are coded and each category has specific definitions. Elizabeth mentioned trying to have the clinician NP work up to his or her license and not do the same level of work as the RN. So what are your thoughts on that question that Katie had about nurse visit reimbursement billing rules varying by state? They were saying that they only have one NP and the rest of the staff are RNs, but they do very similar visits as the NP in general.
Yep, so it's a good question. So my sense is that it may vary by insurer. So the other thing, the insurers dictate so much about, they dictate everything about what can be reimbursed. So part of the question is what's allowed by the state. Part of it, I think the other more important question is what do the major insurers in your area allow for reimbursement? So my first query would actually be to the major insurer or 2 or 3 of your state to figure out whether or not they reimburse nurses for certain care and at what level and follow up. And my guess is that will vary per state.
Awesome. Okay. And thanks again to everyone who is replying to Katie in the chat box as well. So we are at 3:59 Eastern, and I want to be respectful of everyone's time here. So I want to send another thank you to Wendy and Phil, our wonderful presenters for today. Thanks to you all for attending as well, especially given that you all likely have very heavy workloads with all that's going on during the pandemic. So I'll ask that you please complete the evaluation after the webinar ends. You'll be automatically redirected there, but Desiree has also put it in the chat box. The recording of this webinar and the slides will be emailed to all those who registered, and it will be put on the NCSD website. If you have additional questions for our presenters or for me, Leandra, at NCSD, our contact information is in the slide deck. And if you're in need of specific STD clinic TA or 340B TA, you can contact me, and I'll put you in touch with my colleague, Jenny, Associate Director of Clinical Programs, or Stephanie, who's our Director of Policy and Government Relations, as I mentioned previously. So I hope you all have a wonderful day, and I hope you all stay safe. Thanks all. Have a good one.
Thank you, everyone. Take care.